Immune thrombocytopenic purpura. Immune thrombocytopenic purpura (ITP) is the most common thrombocytopenic disorder. It was previously called idiopathic thrombocytopenic purpura because its cause was unknown, but it is now clearly considered to be a hemorrhagic autoimmune disease that results in the destruction of platelets. Etiology and risk factors. ITP is an acquired disorder in which circulating platelets are destroyed because of autoantibodies that bind with antigens on the platelet membrane. Although the platelets perform normally in the bloodstream, they are recognized as foreign and are destroyed by the macrophages when they reach the spleen and liver. The decrease in the number of platelets results in bruising and spontaneous bleeding into the skin and mucous membranes purpura. Platelets normally survive 8 to 10 days within the circulation. With ITP, however, platelet survival is as brief as 1 to 3 days or less. ITP may be acute or chronic. In most cases, the course is one of remissions and exacerbations that, if untreated, may continue for years. Chronic ITP occurs most commonly in women between 20 and 40 years of age. Clinical manifestations. Clinical manifestations include petechia ecchymosis, epistaxis, bleeding from the gums end, easy bruising. Women may have extremely heavy menses or bleeding between periods. Diagnostic findings. A platelet count below 100,000 per cubic millimeter, prolonged bleeding time with normal coagulation time, all coagulation factors are present and normal, increased capillary fragility is demonstrated by the tourniquet test. Positive platelet antibody screening. Bone marrow aspirate containing normal or increased numbers of megakaryocytes. Complications of ITP. 1. Spontaneous cerebral hemorrhage, which proves fatal in 1% to 5% of clients with ITP. 2. Severe hemorrhages from the nose, GI tract, and urinary system. 3. Bleeding into the diaphragm, which can result in pulmonary complications, and 4. Nerve pain, extremity anesthesia, or paralysis resulting from the pressure of hematomas on nerves or brain tissues. Outcome management. Idiopathic thrombocytopenic purpura is treated with high-dose corticosteroids to inhibit the macrophage ingestion of the antibody-coated platelets. Plasmapheresis is sometimes used as short-term therapy until the steroid therapy takes effect. If the client is actively bleeding or requires surgery, IV gamma globulin can be used to increase the platelet count. If the client does not have a sustained remission, splenectomy may be needed. In 60% to 80% of cases, removal of the spleen results in complete and permanent remission. Danazol, Danacrin, has been used with success in some clients. Immunosuppressive therapy used in refractory cases includes vincristine, vinblastine, Velbin, azathioprine, Imurin, and cyclophosphamide. Nursing interventions. Institute bleeding precautions as follows. 1. Provide a soft toothbrush for oral hygiene, avoid flossing, hard toothbrushes, and commercial mouthwashes containing alcohol. 2. Instruct the client to avoid blowing or picking the nose, straining at bowel movements, douching or using tampons, or using razors. Men and women should use only electric shavers during the neutropenic phase. 3. Do not give any intramuscular, IM, or subcutaneous injections. 4. Do not insert rectal suppositories. 5. Do not give medications containing aspirin, and instruct the client to avoid aspirin-containing medications. 6. Avoid urinary catheters whenever possible. If a catheter must be inserted, use the smallest size possible, lubricate it well, and insert it gently. 7. Avoid mucosal trauma during suctioning. 8. Remove all potential hazards and sharp objects from the environment. Sharp corners or edges on furniture should be padded. 9. Use a pressure-reducing mattress, and turn the client frequently to prevent pressure sores. Use bed cradles to protect extremities. 10. Avoid overinflation of the blood pressure cuff, and rotate the cuff to different sites. 11. Avoid prolonged use of tourniquets. 12. Use only paper tape, and avoid strong adhesives that may cause skin adhesions. 13. Teach the client and significant others or family members to institute bleeding precautions during periods of thrombocytopenia. 14. Monitor the client at least every 4 hours for manifestations of bleeding, such as ecchymosis, petechia, epistaxis, gingival bleeding, hematuria, occult blood in stools, enlarged abdominal girth, disorientation, confusion, and changes in level of consciousness. 15. All urine, stools, and emesis should be tested for blood. 16. Take and record vital signs routinely, noting manifestations of altered tissue perfusion related to anemia, increased respirations and pulse rate, decreased blood pressure. 17. Check the platelet count, hemoglobin level, and hematocrit daily. Report a hemoglobin level of less than 10 grams per deciliter and a platelet count of less than 20,000 per cubic millimeter. 18. Administer packed RBCs and platelets as ordered. Keep a current blood sample in the laboratory for cross-matching if needed in an emergency.